Cardiovascular aging is commonly portrayed as an inevitable consequence of wear and tear, a gradual stiffening of arteries, weakening of heart muscle, and rising blood pressure that accompany the passing of decades. However, mounting biochemical and clinical evidence suggests that this decline may be far more dependent on nutrient status than once believed. In particular, the role of coenzyme Q10, CoQ10, in maintaining cardiovascular health reframes much of what we consider vascular aging as the outcome of progressive nutritional insufficiency. CoQ10 is not merely a cofactor. It is a vital component of mitochondrial energy metabolism, antioxidant defense, and membrane integrity in the heart and vascular system. As levels of CoQ10 diminish with age, the heart's capacity to generate energy and resist oxidative stress diminishes in parallel. But the crucial insight is this: CoQ10 levels don't fall because time demands it, they fall because synthesis falters and precursors run low. When CoQ10 is restored, so too is cardiac performance, making the case that vascular aging is, in large part, a preventable and reversible form of nutrient decline. CoQ10 plays a central role in the mitochondrial electron transport chain, acting as a mobile electron carrier between complexes I/2 and complex 3. This process is the basis for ADP synthesis, the energy currency that powers every heartbeat. The heart is uniquely dependent on high levels of ADP due to its continuous, unrelenting contractile function. In fact, cardiomyocytes contain some of the highest mitochondrial densities in the body precisely because of this energy demand. A deficit in CoQ10 directly compromises this energy generation, leading to impaired cardiac output, reduced endurance, and ultimately, structural weakening of heart tissue. This energy-starved state mimics many of the characteristics associated with aging hearts, but unlike irreversible damage, it reflects a specific, correctable deficiency. The synthesis of CoQ10 within the body is a complex, multi-step process requiring the amino acid tyrosine, B vitamins, especially B2, B6, B12, folate, and several steps of the mevalonate pathway shared with cholesterol synthesis. As we age, the efficiency of this pathway declines, due in part to both enzyme downregulation and diminished availability of the necessary cofactors. Furthermore, statin medications, commonly prescribed in older adults to lower cholesterol, inhibit HMG-CoA reductase, an upstream enzyme that not only reduces cholesterol production but also CoQ10 synthesis. This creates a scenario where aging individuals, many of whom already have lower dietary intake of CoQ10-rich foods such as organ meats and fatty fish, experience a rapid depletion of this critical coenzyme. The result is mitochondrial inefficiency, increased reactive oxygen species, and accelerated endothelial dysfunction, all hallmarks of cardiovascular aging. Yet, this trajectory is not inevitable. Numerous studies have shown that CoQ10 supplementation in older adults, especially those with heart failure or hypertension, leads to improved cardiac output, better ejection fraction, lower inflammatory markers, and even enhanced quality of life. One landmark trial, QSymbio, demonstrated that long-term CoQ10 supplementation in patients with heart failure significantly reduced cardiovascular mortality and hospitalizations. These are not subtle effects, they are clinically meaningful shifts in outcomes, achieved not through synthetic drugs, but through the replenishment of a nutrient the body no longer makes efficiently. The antioxidant properties of CoQ10 also contribute to vascular health. As a lipid-soluble antioxidant embedded in mitochondrial and cellular membranes, CoQ10 protects lipids from peroxidation, particularly in low-density lipoproteins, LDL. Oxidized LDL is one of the main initiators of atherosclerosis. Thus, a lack of CoQ10 not only undermines energy production but allows greater oxidative damage to accumulate in arterial walls. Restoring CoQ10 may therefore reduce the initiation and progression of vascular plaque formation, not by removing cholesterol, but by preventing the oxidative stress that transforms cholesterol into atherogenic particles. This reframing of cardiovascular aging has far-reaching implications. If mitochondrial failure and vascular decline are largely consequences of nutrient shortfall, particularly of CoQ10 and its cofactors, then the solution lies in nutritional repletion, not merely symptomatic management. This is not to suggest that CoQ10 is a panacea, but rather to recognize that its role is foundational to the system we are trying to preserve. Heart disease is not just a result of lipid imbalance or genetic fate. It may be, in many individuals, a prolonged period of undernourishment in the face of escalating metabolic demand. Importantly, restoring CoQ10 function also improves resilience. The elderly often experience reduced exercise tolerance, slower recovery from illness, and increased vulnerability to metabolic stress, all conditions that correlate with mitochondrial dysfunction. Supplementing CoQ10 has been shown to improve physical performance and reduce fatigue, not only in heart failure patients, but also in otherwise healthy older adults. These improvements in vitality reinforce the idea that energy production, not time, is the deeper limiting factor in functional aging. In conclusion, the story of cardiovascular aging must be re-examined. The heart is not doomed to decline because of its age. It struggles when it is starved of the very molecules that power its every beat. CoQ10 is not optional for heart health, it is essential. Its age-related drop is not random. It reflects nutritional depletion, enzyme downregulation, and pharmaceutical interference. When we understand this, we stop viewing aging as a mystery and start seeing it for what it often is: malnutrition of the most critical molecular machinery. The heart can still beat strong, provided it has what it needs to do so. Aging does not take away that ability, only deficiency does.